So cool to have such a great panel up here. Good afternoon. I'm Diane Roylance. I'm part of the Pain Society of Alberta, and I have the privilege of moderating this session this afternoon. If I'm mumbling, wave, get a hook, whatever you need to do. And just while everyone's settled in, I know some people are scooching over after work, trying to get in on their lunch hours. And just as we settle in, I always like to it's Friday. I love Fridays. So take a breath, settle in a little bit. I always find it helps me when I'm getting settled in. And I'd like to acknowledge today that just in the spirit of us gathering today to work on healing, sometimes our own, sometimes the people we work with, I'd like to just recognize the current people, healers, and those who have passed through this territory of Treaty 7, the Blackfoot Confederacy, and part of Métis Region 3. And in the spirit of reconciliation and truth, I honor the people and I strive to listen. So that's why I'm here today, and thanks everyone for being here. Now, a couple housekeeping items. We are recording the session this afternoon, and so if you don't want to kind of be in the line of sight, the perimeters are better places to be, okay, in terms of situating yourselves. And other than that, I think we'll get started. I'd like to thank a few people today. I'm not going to do the whole laundry list, but I'd like to thank the Pain Society and our APEC committee, and then really big shout out and thank you to the Joint Planning Committee. We had a pretty big crew, sometimes changing cast of characters, lots of folks from down this way and some folks up our way, and you'll see all of those names on the rolling slide this afternoon. So thank you so much, everyone, for that. And today is a session that's we couldn't have done without the support of the Southstone Primary Care Network Committee. So thank you so much to them for their very, very generous support. Yeah, amazing. And we're so grateful. We'll be taking a mid-afternoon break this afternoon for bathrooms and a snack and coffee. And if any of you are registered for tonight's session, please keep your name tag, okay? Because we're just going to keep those a one-off deal. And apart from that, I will get going. So I'm going to introduce the panel first. And I think I'll just refer to folks by their professions, not that I'm labeling everyone. And then if you want to see where they're working, if you're not familiar, that'll be on it's in the information. So we have Penny Kowalchuk over there. Penny's our person with lived experience, I think the most important person on the stage. Suzanne Buchanan is nurse practitioner here. Dr. Carlos, I don't think, didn't arrive. I'm not sure. Anyway, he was supposed to be here, but unfortunately, he's not. Drake McShane, thanks Drake. Amanda Soyak is there, wound care specialist. Jignesh Desai is at the end, yeah, pharmacist in town. Martha Butler is our star on Zoom, so she'll be joining us from Calgary today. Martha's an OT. With lots of experience in pain. Rory McMullen is over here. Physio, Trevor Saskich. Yep, hi Trevor, is a kinesiologist. Engel Gunn, physio in private practice. Shanna Wandler is there right beside me. Koji Duncan over there, who is an earthotist. Suzanne Conrad at the end. Hi Susan, thank you. Social worker. And Tracy Kwasny, a dietitian. No. Yeah, there you are. I'm sorry, you're hiding there. So we've got a really wonderful, sort of rich group of people up here under one roof, which is great. So that's our star lineup for today. No pressure, you guys. So I will ask Dana Garden to come up and just do a summary of the case, and I'd like to thank her and our colleague Ashley Smith for putting this case together today. You all received that in your email to refer to, and I'll just let you come on up and do a little quick preamble here, just to remember. Thanks, Dana.
Good afternoon, and thank you all for coming. Thank you, Diane, and our Alberta Pain Education Collaborative Lead, and Sylvia from the Pain Society of Alberta for all your work in planning and organizing this event. And thanks, as Diane said, to Ashley Smith from the Cummings School of Medicine for pulling this case study together with me. Now, hopefully everyone has had an opportunity to do a quick read-through of our case study today. Before we get to our panel, though, and as mentioned, I'd like to do a little overview with you just to set the stage for our discussion. This case study will likely feel pretty familiar to most of you, as back pain, and moreover low back pain, is a common complaint in both the outpatient and inpatient settings. So we are presented with Amy. She's a 52-year-old woman. She has a busy life, lots of responsibilities. She's had a seemingly minor fall, but in the background, she has had recent acute stress given the passing of her father. Unfortunately, the end product for Amy is low back pain that doesn't settle. Like Amy, when we have little injuries such as this, we naturally assume that within a few days, our pain will subside and we'll be back to business as usual. Like Amy, we'll often try a few things on our own before we consult our primary care provider. Most often, we'll try physiotherapy. Sometimes we'll have another little injury to set us back. Like Amy, when we see our primary care provider over more than one visit, and when our conservative management has failed, we may eventually end up having some screening tests, imaging, to rule out anything more sinister. We may even be provided a short prescription of low-dose opioid with the initial good intention of it being just enough to get us back on our feet again. We find out for Amy that this doesn't end up happening. Amy doesn't rebound as hoped, and she finds herself modifying and then reducing her work responsibilities, hoping moving less would hurt less. She also ends up increasing her analgesic use. And although she feels guilty about using opioids, it does seem to help her get through her day, and her guilt over loss of function is at least on par with that of her opioid use. And to begin with, her loss of function is more difficult than her opioid use to hide. Unfortunately, within this story for Amy, as she juggles her injury with her commitments, something is also happening at the brain level which isn't helpful to healing. She finds a lot of fears creep in because things aren't going as anticipated. We can assume that Amy is beginning to assess that her injury was far more serious than originally thought. Maybe the x-ray missed something. Maybe a second opinion is needed. And Amy thinks maybe I'll never get better. Now, instead of just hearing the flute, Amy has the whole orchestra joining in. At this point, she starts to receive messages from her brain imparting doubt, and also nearby anatomical structures starting to react as well. Amy's pain experience is now amplified. Even after enough time has passed to provide healing, Amy has learned to equate pain with movement. As Amy continues to do less physically, she loses more of her baseline conditioning. She feels defeated. In this setting, we are often more fatigued, so we might eat more. We might take more medicine, with the side effects to boot, just to keep our head above water. We often seek a surgical answer even when there isn't one. Our relationships might fail, just as in Amy's situation. Our mood and sleep might suffer. She is also perimenopausal, which provides an added complexity. Alongside, Amy is developing opioid dependence and tolerance. We can see this downward spiral happening, but we just can't find the brakes. So today we want to talk about what we can do as healthcare providers for our patients when pain has entered that chronic 3 to 6 month phase. Some of this discussion should also inform us about how we could potentially nourish a different healing journey. What could have happened if we were gifted a do-over? We now have some topics prepared to move us into our panel discussion, and I'll turn the mic back to Diane to guide us through the rest of the afternoon.
Awesome. So hopefully that just gives everyone a little bit of a review about who we're going to be having in our minds picture today. And I think we all have someone probably we've seen in clinic or even people in our lives, sometimes ourselves, that may have these experiences as well. So I'd like to we'll do the rules of engagement for the day just to get the panel warmed up. We won't play the name game because I'm not really good at that. So we have mics that we'll be passing around to everyone. Okay, feel free to chime in. We have Martha on the screen, and I've asked Martha just to jump in if when she has things to add. And also, Penny, I'll really encourage you to bring us back to reality when needed about what that's like on the other side. Okay? No pressure either with that, because that's a big thing, and it's not your responsibility to change how we practice. So thanks for being here. So the first question that we're going to tackle today is this notion, as Dana said, what if we had the chance to do this again? Which is maybe not the most healthy psychological space to be in, but it is worth doing those things for learning. So the first question I'm going to put to the panel, and we'll have time at the end for people to chime in with their own questions. When looking at this person, we'll call it a human because it is, what variables were present pre-injury that predisposed Amy to have pain that persisted? So I just want you to percolate in that, and then those of you in the audience kind of think about some of the things that you thought of as well. So let's just start thinking about that a little bit. And what I might do is, given that Martha's on screen, Martha, can I ask you to jump in and just share a couple of thoughts with us? You are on mute still, dude.
You think I'd never done that before. Okay, thank you. It's a little strange talking like this because all I can see is myself. But I'll give you my 2 cents. So I think there are some pre-injury variables to be aware of in this case. And some of them were spoken to in the introduction. So the fact that she is experiencing acute grief or was experiencing grief right before she had her injury is significant, as well as her history of depression. So her brain has likely been giving her sad messages. She also has had stress in her life. She has children, which innately result in some stress. Her work, it was identified that she feels stressed by some of the other people's behavior. But that social stress physically, she also has been, she has a primarily sedentary job, which is hard on the body. She also has a history of IBS and migraines. These are 2 other chronic conditions that often can be comorbid with chronic low back pain. And she was also having a relatively low level of physical activity. One thing I do want to speak to is that her weight, although she was overweight 5 years ago, that's not considered to be a risk factor. But the fact that she's now become obese is a risk factor going forward.
Awesome. Thanks, Martha. Those are great thoughts, and let's maybe expand on those a little bit with others that would like to chime in. Who'd like to put in the hot seat next? Okay, yeah, I see a mic floating down there. Go for it.
Hi. Yeah, so I can see that she was able to take Tylenol 3, which was covering her pain initially. She needed just a 1 or 2. But now gradually her pain also increased. So we need to keep visiting the doctor more and more and increasing the pain meds as well. Also, for her father's death, she also in a stressful condition too. So her depression is also increasing as well. And in the past history, she has taken some history of the citalopram or antidepressant as well before, but she is not taking right now. And also, as per her age, she is a 52, which is maybe pre-menopause. She's also experiencing the symptoms as well. So if she can start with that one, some kind of the treatment with that one, it will helpful to her too.
Awesome, thank you. This is why it's so good to have so many disciplines under one roof today. Suzanne, go for it.
Yeah, so I was just thinking about this case from a nurse practitioner lens or a clinician lens, and looking at this great panel, I would do referrals and call it a day. No, just kidding. just kidding. When we do see clients coming in that, they are often coming in, maybe they've tried a little something at home, they know something has happened, and now they're looking for answers from somebody who should have knowledge. As a nurse practitioner, we have advanced training, but we don't have all the knowledge. So we do really rely on a multidisciplinary approach with our clients. And I think one of the things when I read this case is it's never just cut and dry with pain management, as probably most of you know here. It's always complicated, and everybody is on their individualistic journey, and what will work for one person may not work for another. So really, as we start the assessment process and we start the treatment process, we're going through steps and trying things and making referrals, realistically, yes, but also we're often seeing those clients come back into our clinics. This didn't work, that didn't work. Sometimes pain, the longer we get out and the more that we try and we're not finding anything, it's, where is this coming from? How are we going to help our clients get through this journey? Because maybe they can't go back to where they were before their injury happened. So it's a really complicated process, and there never is an easy answer. It's probably the number one conversation I start having with clients right from the get-go. You want to give people hope, because if you look at what that client has gone through personally, they have gone through a process of grief. They could be still grieving. They're going through a process of loss, so there could be lack of self-care happening and a multitude of issues going on. So really just kind of gently going forward and asking that client maybe where we can meet them. How can we help you, instead of me giving you advice always and just being the one to take control. I'm finding that in my practice is a good start for approach for this case.
Yeah, thanks very much, Suzanne. And I really like what you just said about that predisposing bit around self-care and health before anything else reaches that tipping point as well. I'm curious to hear from this side of the gang. Yeah, go for it. Jump on in, Drake, yeah.
Just want to make sure I'm not cutting people off. So I guess where I'm going to come in with my lens, so I'm here as a registered nurse. I guess where I fit in, because I know nurses are kind of a bit of a Swiss Army knife, I'll just talk from like the pain science aspect. So for me, what I'm passionate about, as well as like what's clinically relevant for me, would be assessing like emotional injuries, as well as seeing what level of central sensitization is going on for this person. So just expanding on what Martha said, yeah, she has the comorbidities of IBS and flipping my pages, but there was a couple other ones that were on there. But we want to ask, how have you also been managing those too? Is that something that brings you a lot of worry? Is that always on the forefront of your mind? Because that's something that could predispose her to developing kind of like some pathways in her brain that are predisposing her to worry. So when she actually has this physical injury or that fall, it's now this gold mine for this is something to worry about, and the brain can kind of circulate that on that a little bit. So for me, what we're looking at with her pain, like going over 3 months, we're trying to assess, okay, she's done physio. From a structural perspective, I'm actually not super concerned on what's going on for her. There's 3 types of pain, if you want to write stuff down: nociceptive, neuropathic, and nociplastic pain. Nociplastic pain is the one that people go, huh? So nociplastic pain is looking at basically, we'll just keep it simple for right now, but it's when that volume knob gets cranked up. So the pain is still very real. We have to make sure we're validating that, and that's something that there's some really, really cool research coming out with functional MRIs that are validating this stuff. That's showing like the brain as an organ is involved. Who would have thunk? But when we look at the brain being involved, it's not now suddenly in the person's head or anything like that. We're looking at the brain as an organ. just like we would the heart or the kidneys. So I'd be curious, there's an assessment called the CSI, the Central Sensitization Inventory. I'm going to guess if we were to do that before her fall, it would already score pretty high, so that she already had these pathways predisposed to worry. So when that injury happened, it kind of keeps that pain perpetuating. When we look at pain pathways in the brain, without going into all the specific reasons, we'll just say that there's two. There is a suffering pathway, so if we look in the middle of the brain, that's like the suffering, the limbic system there. This is that emotional component of pain. And then we have the physical component. What hurts? What does it feel like? Is that burning, shocking, throbbing? All of those fun descriptive words. Both of those pathways can set off pain. So if we have that suffering pathway keep going, that worry, then that can kind of keep that pain circulation going, even though the tissues might actually be structurally not as damaged as they feel. So anyway, long story short, the emotional injuries would be what I would look at.
Thanks, Drake. Yeah, thanks, Drake. That's great. And I think it's always really interesting, too, to think about this global approach of sometimes people don't think about gut issues being central issues, which, there's lots of great research to support that. But sometimes when we're not having those overarching conversations, of course, as you say, we forget that that might be almost like a risk factor, which it is, as it turns out. Yeah, exactly. Bingo, go for it. Yeah.
Looking at her pre-morbid situation, a few things that came up for me was there's clinical pathways and they're always being developed. And there was one study I looked at where it said, when we look at clinical pathway for back pain, the two things to avoid was x-rays and putting them on opioids. And we're like, oh, broken the rule here. And I think we've all seen the minute you start doing the x-rays, there's places where they're appropriate, but you start the catastrophization for a person. And once they get into that cycle, that's really hard to break because they're like, there's something more happening and you don't know what it is, but there's something more. So you can't get past that. And when you look at this person's pre-morbid mental health, depression, a little more worry, IBS, a little more worry, a little more prone to worry, migraine, that sensitivity to situations. You can see the red flags, and then you really have to put out that fire of catastrophization. And that's where I think, and it's often the link I've missed till it's too late and they're in that area already, is pain education. So we know about it because most of us have learned it clinically, but they don't. It might be a plumber's coming in and just teaching them about pain and about the cycles of pain and teaching them, look, you got to break that cycle. And as a physio, it's often, we got to break it with movement. Yes, so medications can help you move, but we got to get this body moving because worse things are going to happen. But I have to avoid saying the word worse because that catastrophization thing. So,
Beautiful, thank you, and very clinically relevant as well. I'm just wondering, Penny, can I ask you a question that's related to this? And I think this is always interesting. We know that imaging isn't helpful often, not always, but often. And yet, as someone who's living with pain, it kind of makes sense that you might want to find out if there's something more sinister going on, something stronger. So for you, as a person with lived experience, how helpful or unhelpful are x-rays in your experience? And again, not to diss x-rays, just use it as an example.
Well, I feel like there's times where investigation is important, but there's also times where you might not get an answer. You might not find an answer. And in my experience, I have a widely affected family who have Ehlers-Danlos syndrome. So a lot of the things that we experience and a lot of the pain we experience doesn't have something that's identified on an X-ray. The most alarming thing I've heard here so far were two things. And actually, it's funny because on my presentation for tonight, they're on my list. The first one is the focus on opioids, because I feel like opioids are a tool in the toolbox. For some people they help, for some people they don't, just like any other treatment. But because of the recent opioid crisis, the focus has been put on opioids as a scary, dangerous thing, when in reality, patients that take opioids appropriately for something that they really need them for, it's less than 2% of people that become opioid dependent, or like that have an opioid use disorder, sorry. And so I feel like, well, that is part of the picture. It's not the main part of the picture. I mean, I spoke with our local MP, and she said she was on a committee investigating the opioid crisis, and she was surprised by the fact that people were talking about doctors and prescribing as part of the problem, because she said in their investigation they said that wasn't part of the issue. It wasn't poor prescribing like in some of the southern U.S. and so on. It was illegal fentanyl coming in from other countries with other goods, shipments of other goods. And that's where the source of the problem is, and that's where the problem lies. And that's what needs to be addressed. So I would like to say that the stigma associated with them and the attention that is paid to them as like the first line is harming to patients that are required to take them for one reason or another. And so that's one thing. And then the other one is, I'm just going to look at my notes because I'm just coming through an illness, so I'm not quite, my brain's not firing on all
We all need
cylinders.
notes. They're good.
Okay.
Yeah.
Oh, the pain being because you're overweight, because that is usually the first thing that somebody brings to a pain patient when they come into their office is, you're overweight. If you could just lose a little weight, then your pain would reduce and you'd be better. And that's not always the case. In fact, my pain hasn't gotten better, but I've lost 25 pounds. It's not necessarily linked. And the loss of the 25 pounds, is great, and I think everybody should focus on that, but I don't feel like that should be the first thing that we talk about when we talk about a pain patient. And I'm with Drake in that what we need to focus on are what tools work the best for the patient, what have they seen benefit from, and then trying to increase the quality of life for the person. And what does that, whether it be, I mean, I had a whole list of things here. Sorry, Drake, could you hold that for 1 second? I just want to make sure, I just need notes to remind myself, I'm sorry.
I'm right there with you.
So let's say if they've lost their job, they could be encouraged to seek out a position in a field that, as a volunteer, that brings them joy, something they love to do. So that would be something that would lift them away from thinking about the pain and being absorbed by the pain, and give them some other point of focus, which often helps to minimize the pain in my experience. Maybe they can work from home if they can't work at their regular job. Maybe they can find alternative treatments that somebody hasn't thought of, like shiatsu or any kind of alternative massage, Theracanes that you can do yourself if you can't afford massage, deep tissue massagers, and having safety equipment in their home that takes the pressure off that area that was injured. Finding other ways to be active that they enjoy, that if they couldn't do the things that they did before. For example, for me, I can't run anymore, but I can run on an elliptical. So that's my feeling. I really feel like each patient needs to be looked at as an individual and listened to and treated like a team member in their own solution. And And that's sometimes what I find lacking, but I got to tell you, I spoke to my family doctor yesterday and I said, if I were speaking to a group of clinicians, what could I tell them that would encourage them, if they aren't already, to treat their patients with the same level of respect and compassion that you treat me? And does anybody have an idea what he said? He said nothing. There's nothing I could say. And I don't like that answer. And the reason I don't is because I feel like it's a product of the situation we find ourselves in Alberta right now, which is the shortage of doctors. Doctors are, or not just doctors, all medical practitioners and clinicians are completely stressed to the max and discouraged and tired, just like the patients are. And so I feel like in the same way that the patients need to be encouraged to find ways to bring hope and joy and distraction, quite frankly, into their lives, the clinicians need to do the same. And then work as a team. Those are my thoughts.
Those are all great thoughts, and I think we need them on a T-shirt backwards so we can look at them in the mirror every day at work. Hey, thank you. No, and this is why it's so great to have you part of this panel, just to keep it real. Absolutely. Yeah, totally. I was just going to come over this. Go on in, Shannon. Jump on in.
Perfect.
Yeah.
So just to kind of take off where you left off with the quality of life piece. So my role and part of the panel is I'm coming from the therapeutic recreation lens. And when I was preparing for this panel discussion, the first question around predisposition to pain that is longstanding, typically we don't see individuals prior to the onset of pain. And the more I was reflecting on it, I was like, this is awesome. She had some interest. She was enjoying yoga. She was enjoying running at some point. She's out hiking with her family. And thinking about the quality of life piece, that's what I was thinking. I was like, here, my role, or therapeutic recreation's role with individuals living with chronic pain is what can we do to bring them meaning, joy, happiness, and wherever they are on their journey with chronic pain. It might look different. It might be emotional in terms of just recognizing and processing. Maybe it's just diversional and forgetting about the pain for just, an hour out of their day. Maybe it is more of a physical approach and getting involved in the aquatics or adapting around not being able to run anymore, but now going on the elliptical, but still having success there. And the more I thought about what predisposes her to have that ongoing pain, I was like, she has great skill sets that can really set her up for success with the right encouragement and a supportive environment. The hard part is that we don't always see those individuals until that pain has now lived on for multiple months or potential years. And then we're faced with that uncertainty, that hesitancy of, can I do this? Should I do this? How do I manage, going to another appointment? And I'm managing my family. I got financial considerations on the go. I'm not sleeping well, so my energies, how am I going to work in one more thing that isn't a medical appointment? And for us, that's where we want to say, how can we support you to incorporate this in a successful way so that each step along the way, you're experiencing confidence and an increase of self-efficacy that you can really continue going forward, whatever that might look like.
Yeah, thanks. Those are great thoughts. And, as we sort of cross-pollinate all of these potentially predisposing or kind of setting the scene features that this human had going on, it also could be any one of us as well, which I always think is important to remember. None of us are special with this stuff. Anything else that anyone wanted to chime in with around predisposing, or things that you would wonder, questions even? Because sometimes, there's things that our brains do around these things of I wonder, did she have footwear issues, or did she have, were there things that she used in her house that she was already using to try and make life more efficient? Anything else that anyone, yeah, go for it, Roy, yeah.
Hi, my name's Rory. I'm one of the physiotherapists on the panel. What's that?
I stacked the panel.
Yeah, sorry, thank you. The one thing I thought about, as in something that would predispose this patient to having pain, even after a physio intervention is well, what did that physio intervention look like? Now, physiotherapy is a huge trade set. Some people focus on, we were talking today, needling, dry needling, acupuncture, some passive treatments, and then there's physiotherapists that do more active style of treatments, and that might be conditioning, strengthening, returning to activity, those kind of things. So when we think about what allowed this patient to have pain 3 months later after even going through a physio intervention, for me, I'm skeptical and wondering, well, what was the physio intervention, right? So what actually happened? Was there goal setting, or was there the patient coming down, laying passively, someone working on her, and see you later, talk to you next week and do it again? Or was that person actively involved in goal setting and working towards returning to those functional things that she enjoyed? I've always found that when I get lost with an intervention, I always go back to being like, oh, did we set goals? And if we didn't set goals, then I look back and thinking, oh my goodness, we didn't set goals. No wonder why we're lost. And then we get into this goal setting intervention, which then helps guide it. And it puts, like one of the panelists said over here, it puts the power back into the patient's hands to say, well, what's important with you? Maybe there's an emotional thing that's going on that I may or may not have the skill set to help with. And that might instigate a proper referral to someone that could do it. Because if that's the barrier for the patient to move forward, I think we need to address it. But for me, I think, what was the style of intervention prior?
Yeah, great. Really great input. And you're twitching with your mic. Do you want to jump in? Yeah, go for it. Yeah. This is awesome.
Perfect. Hi, I'm Trevor, everybody. I'm a kinesiologist and exercise physiologist. So coming in my role, working with maybe a person such as Amy here, looking at the relationship with movement prior to the injury as well, how that might have changed afterward, and what the expectations may be at this point surrounding movement. So it seems as though that relationship with activity and movement is now transformed to something that might have more of a negative context surrounding it as well. So also looking at different predisposing factors with the understanding that prior to she enjoyed yoga and light jogging, what kind of brought into that activity prior to? So were there predisposing aches and pains that alarm system may have already been turned up before, that we were trying to turn down the dial using these activities? On top of that, what brought running about the light running? Was it, all of a sudden we just started to jog and those posterior muscles got overloaded, and then we were trying to, maybe a predisposing factor if there's that tightness going on there already. And at this point, how then do we start to change a few of those expectations around, or get a better idea of what tools are needed in this? I know an analogy that I'll commonly use with clients is, you are the journeyman contractor, the journey person contractor, we are simply Home Depot. I don't want to give you a saw to put a nail into the wall. What do you feel as though we need to set up these expectations in a way that healthy then promotes this activity and start to bring back that movement in a graded fashion that helps us positively rather than reinforce that negative relationship? So just looking at those predispositions as to how does this make us feel?
Yeah, great, thanks. Anyone else that wanted to jump in on this predisposing idea, or things that have come to your mind since then at all? Okay, yeah, nice. It's interesting, I'm just thinking, I listened to a lecture recently by an Irish physio, not this one, but another one, and he was talking about this notion, which will come up today, around supported treatments and active treatments. And it's interesting, even things like needling and manual therapy in the physio realm, or manipulation and manual therapy in the chiro world as well. You can do that in a very active way if you choose to, right? Those things can be very engaged and very collaborative, and that's a choice sometimes too. And that's always interesting, right? Just how we do those things. And again, Penny, as you had said, who's involved in that room? Who's in the room in that moment? And granted, we all have days where it's a tough day and you just need some help and you need to feel a little bit better, and that's okay too. So just looking at the mixed bag of things, that's great. Yeah, nice, really nice thoughts. Now, the next sort of question, these ones all sort of cross over with each other, and we've touched on some of this. So once Amy reached that sort of 3 to 6 month phase of her pain experience, what kind of things do you think, if you had to do it over again, what other things would you like to see happen? We've sort of talked about them at a high level, and I'd like to kind of dig in a little bit now to what that might look like, sound like, feel like, and just to be specific with some of those things. So say Amy's in your office, room, gym, space, business, at your counter at the pharmacy. What kind of things would you want to do differently in that phase? Because it's kind of a little bit of a shift on even physiologically as well. So I'll throw that out to the panel to talk some specifics around that 3 to 6 month mark. Yeah, go for it. Don't be shy, you guys. This is great. Jump on in. I'm a small town gal. I love this.
Yeah, when we're hitting that point that, typical treatments that would heal an injury or they'd be on their way to recovery and doing well, and that's not the case. We want to be curious as clinicians and find space to listen, and if you don't have the time in your clinic, then that's kind of where, we have different panelists that can support in different areas here. But as soon as we enter those phases where we're entering the chronic pain realm, then that is where we have to be curious and ask what's going on, not just, deny someone's pain. You should be fine, the x-ray looks okay, it's all in your head. Terrible messaging that gets heard daily, unfortunately. So when we get to that point, we want to shift focus and go, okay, what are we dealing with here? And I mentioned the 3 types of pain earlier. We're trying to gather some evidence. Do we have some of this nociplastic pain going on? Is the nervous system involved with this pain pathway? Pain is going on 3 months or more. I'm going to take a stab at say that there's at least a small portion of this going on. So where I'm trying to get to is bringing in pain education, specifically pain neuroscience education, where first off I just ask the patient, what do you think is causing your pain? Usually things would be healed by now, even like a big fractured femur would be healed in a few months. When we're dealing with these big injuries, it's not abnormal for an arm to break and to heal and for pain to go away. Why is this pain still going on? So assessing their understanding of their pain is going to give us a lot of answers, because if they think, every time I move it, I'm crushing my back or I'm really damaging my back, she says she's avoiding certain movements. So her relationship with pain is that every time I have pain, I have tissue damage going on. And I would not have confidence to move if I think I have tissue damage going on. But is that the case? No. So if we start doing some pain education, we go, you're really, really sore, but you're safe. And what we're dealing with now is this nervous system that's overprotective. We kind of hinted at that alarm system analogy. I'm going to expand on it too, if that's okay. Steal Trevor's thunder a little bit, but it's like if we have a fire alarm system that's going off for a fire, and now it's going off for that candle. You can focus on the candle, but it's really the issue of that fire alarm is that sensitivity piece. So that's what we're trying to, we try and shift that patient's whole relationship with their pain. This doesn't mean that their pain now goes away. We think differently, and all of a sudden we can run and do all these things. We have to, again, understand the brain as an organ. So it has, there's some pieces which could be argued as like associative learning with like positions. Every time I do a certain position, I have pain. If you want to bring in that Pavlov's dog analogy, that's kind of what could be going on as well to an extent. How do we repair the relationship between the brain and the body so the brain can fully trust that body and have confidence in it? And again, that's where we rely on physicians to rule out red flags, understand what's going on. Like we mentioned, Ehlers-Danlos as well, where if we have some structural conditions, how do we move within that? But then if we also have this additional nociplastic pain, we want to help give the client some guidance on where are you safe, where should you push, where should you not push, and what's actually going on so they can have some more confidence with their movement. So pain education is what I
Great, thanks, Trey. And Martha, I'll just ask you if I can. You're a master of pain education. I had the pleasure of working with Martha for a number of years, and we've collaborated on some work in the private world as well. And it's just really always really cool listening to her language with patients. Martha, do you have any thoughts sort of at this 3 to 6 month mark about some language or some sort of strategies to share with people around delivering that pain neuroscience, modern pain science, pain education? We're calling it lots of different things. I'd be curious about your thoughts on that.
Sure. I think it's really, really important to help the client to understand that pain is a very complex thing. We feel it in the body, but it's our brain that produces it. And in producing the amount of pain that it does, the brain considers not only the sensory information coming up from the body, but it uses the thoughts that we have, emotions that we have, our memories, our awareness of the environment, all those things in a split second are taken into consideration in the production of pain. And some of those things we have control over and some of them we don't. And so it's incumbent upon us as people to be aware of what are the factors in me that contribute to my pain experience. And where do I have some degree of control? And I think that, the fellow who was speaking before me acknowledged the importance of listening to your client. That is so important from the get-go. And I think it's also really important for us to reflect back to the client when we hear them telling us things that they're doing or that they're using language that represents that they're thinking in a way that is helping to calm down their nervous system. So they're actually taking some control there and reducing the amount of pain that the brain produces. So that they get to recognize that they do have some influence over that. And also to reflect another previous comment about hope. That is so important, that when we're presenting coping strategies, whether they're physical or psychological in nature, that we put them in the context of the client's values, the things that are going to drive what they want to get back doing, so that they can see, yeah, I can do these things and get back to my life, live my life. And as clinicians, whether we're a physio, a rec therapist, a doctor, whomever, we can all recognize when someone's doing something that's helping themselves. And I think it's so important when we recognize that it's very difficult to live with chronic pain, that they get some feedback about what they're doing right and that you're moving in the right direction, and that they are retraining their nervous system. So that was a bit all over the place, but I was trying to reflect on some of the previous comments as well.
Yeah, that's fantastic, Martha. Thank you. And Koji, I'm going to put you on the spot right now. I'm curious. You bring a lens around adaptive assistance and gear, I'll call it, which is, and that's my highest compliment. I love gear. Is there anything that jumps into your mind from your expertise that you think could be helpful or could have been helpful at this stage of the game to help Amy in her experience?
Yeah, I guess there's a few things that I think could have possibly helped her along her way, because she was doing, had some success and was feeling better, and then kind of had a big setback, and then ever since then it didn't seem like she really recovered from it. Kind of stopped on the physio and felt that maybe physio was aggravating things and just not, kind of spiraling downward from there. So where I come in is with orthotics and bracing, basically, is just trying to kind of give that almost like the instant sense of relief where you can, like she could put on a lumbosacral or back brace and provide some structural relief just by limiting motion and keeping her out of those ranges that are causing her a lot of pain, as well as just by increasing abdominal pressure, being able to distract the vertebrae a little bit can provide a lot of pain relief. So I see a lot of people that come in and put them into a back brace and they feel, that instant relief. Now, definitely not the end of the road, because wearing a back brace is not the best thing for your body long term, because then your body starts to become more reliant on it. You start to lose some core strength. So definitely needs to, if you can kind of get her over that first hump to have some relief, then, readdressing physio and getting more active and, starting to increased core strength and stuff like that becomes more realistic, I guess. Like it's not something that she's just afraid of going after because she knows it's going to start causing pain again. So it's almost like a limit a lot of the motion and things to begin with to provide some relief, and then to slowly ease out of that and kind of get back to a normal state where you don't have to rely on a back brace. So like you had said about opiates and things, like it's really just bracing is just another tool in the bag to kind of get you to that point.
Yeah, that's awesome, and I think the sort of the term training tool comes to mind with that as well. And I think, you know, we often, the pendulum swings. I'm getting old, and you see these cycles go through with what's the latest, greatest, and, you know, sometimes it's gone to like it's all just education, or it's all just this, or it's all just that, and it's a mix always for people. And oftentimes I think people are shamed perhaps around, oh, well, you need that? Oh, well, you're not getting better. Not helpful. Who cares what it is? I mean, I've given people some really bizarre things to work with because it's calming in that moment and it creates space. So I sometimes think, well, who cares? Let's figure it out, which, you know, to a point. So that's helpful. Yeah, Penny, go for it. You had something to say. Please jump in.
Yeah, I was just going to say, this is my first time being able to have discussion in a room with this many educated people, but I feel there's a gap somewhere in the research. And from the last question to this question, it's the same gap. Is there research being done on what does predispose people by actually talking to real chronic pain patients and finding out what their life was like before they had the pain? And then while they are having the pain, I can't find any research of any kind, I mean, like not significant anyway, that shows what has helped patients. And the frustrating thing I find for patients that we talk to and my extended family and so on, you go to the doctor and they say, well, that won't work. That doesn't work. This doesn't work, or, you know. But how do they know? Because we're hearing from other pain patients, this works for me. So I wonder if there's a gap there that could be filled that would really benefit somebody like this patient that we're talking about if somebody took the time and put the energy into it, because, yeah.
No, that's a great point, and it's interesting. I remember having a conversation with one of my colleagues who's a researcher around this notion of how we do evidence-based practice, evidence-informed practice, and I think we're all a bit twitchy because we want to do the right thing so much, but often that's paralyzing as well, because then it's like, well, that won't work. But not knowing and having evidence that it's dangerous is very different. And I think oftentimes it's easy to say, instead of saying, well, no one has studied that yet, or we don't know, we're not sure, oh, there's nothing in the literature. Ergo, it doesn't work. We don't know, we're guessing. So I think, again, language, right, around that of, well, we're not sure, what did you notice? And you're right, it becomes a very personal thing as well, that what works for one might not work for the other, but it doesn't mean it's out there. And just to be creative with it as well. Yeah, thank you. Any other thoughts? Go for it, yeah, jump on in. Don't be shy.
So Penny, I think the bottom line for individuals is their ability to self-monitor. So to pay attention to, when I do this, this happens. When I do that, that happens. When I think this, when I feel this, this is what happens. And because pain is so, it's multifaceted. There's so many things that impact how much pain the brain produces. It takes a while for an individual to figure out for themselves what the combination is, even with regards to how they plan their daily activities, right? Because it's a cumulative effect through the day, that maybe, you know, how long you're on your feet is, you can figure out on average how long you can be on your feet. But if it's on the day when your car broke down and you had to change the tire, and, you know, there's other things that happen, that's going to put you over your threshold into a flare up of pain. Or if someone yells at you because you cut them off and you feel upset about that, that puts you over the top. So I think when it comes to the tools that are helpful, it really is individualized and requires the patient themselves to behave like a curious scientist, just to figure out, okay, this is what happens on a day like this. This is what happens on a day like that. What's the common ground here? And it is helpful if you have a clinician to help you sort that through, for sure.
Thanks, Martha. That's a great conversation. I'd love to jump to this side. Go for it. No, you're fine.
So my name's Amanda, and I'm a wound nurse, but I'm a registered nurse, and I work for the Blood Tribe Department of Health. The lessons that I have learned while working with this community is something that I think all of us need to learn. We are focusing on the physical, the emotional, we're getting better at looking at, and the mental. We want to help people with the education. I'd like to bring in the spiritual piece, especially when it comes to pain. You never know the power of their spiritual abilities to heal and help to actually manage or cope with the pain they have. If you actually ask your patients, many times when they come into my clinic room, I go through, okay, we're talking about physical, now we're going to talk about your mental. What do you know? How are you feeling about that? And now I'm going to ask you a question that maybe you haven't been asked before. What are your spiritual practices, and are they going to help you? Is there somebody else that you could reach out to? And I feel like we miss that piece, and that's person-centered care.
Beautiful. That's really nice. I sometimes use that analogy of different parts of your gas tank, right? The spiritual is one of them, and that is such a personal thing and an important thing and different for everyone. Absolutely. Yeah, go for it. Yeah, jump on in.
Okay, yeah, hi, I'm Susan, and I am a mental health therapist and have run group therapy for many, many years, including self-management for chronic pain. For probably about 15 years, I think we've been offering it here in Lethbridge. And so there was quite a few things that came up, and it's all kind of scrambled now in my head. But if there's any way to get people, we never see people at 3 to 6 months. I don't think that they might hear the message like, oh, it's in your head, oh, you need mental health, oh, it's this, it's that. And I don't think people want to come to addiction and mental health services, maybe for chronic pain. So it was kind of this, I think 15 years ago, kind of this partnership that was like, oh, you do group therapy? Could you offer this space for people? And I have found that the connection, the ability to share and validate one another, the shame levels go down, the connection that's made between like, well, this works for me, or this has helped, this hasn't helped. People can take what they want, they can leave what they want. They learn things together and they teach each other. So it's different than coming just from a book. Here's what we know. It's people telling other people with lived experience, this is what I understand from what I've experienced. And then that's how they learn. I have just found it so rewarding to do this type of work with people that I think if there's any way you can convince people to do group therapy, you're going to find a lot more other benefits. There's a lot more meaning in it. People see other people. Sometimes I know in the beginning people might say, well, I don't want to hear about other people's chronic pain. Maybe, or I don't want to hear if somebody's had it for 10 years and you're 3 months in, right? But we come from a place of hope. We do want people to see that there's so many other sides to this, and the way that we offer it, I think people leave feeling hopeful, connected, and heard, validated.
Awesome, thank you. Can I put Tracy on the spot about, because this is an interesting period of time, I think.
I was just going to add to that
thank
a little
you.
bit. So I'm Tracy, I'm the dietitian. I do the nutrition piece in Drake's chronic pain series. And I was just going to add to the group setting. And a lot of times, for example, if I'm speaking about people who are not eating regularly balanced meals and they're skipping meals and saying, are you in more pain that day, right? Or you can put that out to the whole group, because I can talk in theory, like Susan's saying, like in a book, this is what it'll say, right? But then putting it out to the group, like, do people feel this way? Like if you skip meals, do you feel worse that day? If you drink alcohol, do you feel worse? If you're drinking a can of Coke, do you feel differently, right? And it kind of stimulates that group discussion and how they're feeling, and yeah, so I agree with the groups.
Nice. And is there, I'm curious, from a dietitian perspective, because my belief is you guys are highly underutilized in the team, which is interesting given that we've put food in our bodies every day. Anyway, that's another conversation. Is there anything in your experience around this kind of turning point for patients, and obviously it's very individual, that is starting to emerge, whether it's in the evidence or what you're seeing in your own practice, of kind of basics around relationship and food, our relationship with food and our bodies with pain?
I mean, like you said, it's all very individual, right? Like if somebody's coming to see me in the office, and I mean, with Amy in particular, we talked about IBS and weight management, right? So I may go into there with that potential agenda, right? And ask them like, how can I help you out today, right? And it's not, neither of those things. It's just, you know what? I'm really tired all the time. And so then that kind of brings us to talking about, well, what's your day look like? What are you eating in the day? And is it because you're, in pain and you're tired and you don't feel like eating, right? So maybe the focus is, well, how can we prepare for some of those days when you're not feeling like cooking, where you are tired, and just warm you up about that meal prep and the meal planning part of things.
Yeah, that's great. And again, often something that's really impactful for people as well. Thank you. From a medication perspective, I'll ask our nice pharmacist there. At this phase, given, let's pretend Amy, Amy, and she's working with you, the medication she's on. What would be some tweaks that you would be curious about at this time in her experience, sort of in that, moving out of that acute phase and into more of a chronic phase?
Yeah, because I see that when she was managing the pain with the Tylenol number 3 only, then slowly her pain increased too. I would say also they mentioned also that she gained the weight of the 10 to 20 pound, which is one of the factor too, that she's gained lots of weight. It can increase her pain condition too, because she was in a sitting position so long time for the period of the time. So that was also hurting her knees and everything too. So, sorry, I'm so much nervous that it's been her first time speaking on a stage like that.
No problem, you're doing awesome. We're all friends here.
So also is increasing her cardiovascular commodities. She's also pre-diabetic already 2 years ago, right? And also she haven't checked back how she's her A1C or how sugar level, because as she feel more tired, she's just not paying attention on food, on balanced diet or anything. She just grab and eat whatever she feel too easy to ease and let it go and done, right? So that'll be another factor that increasing her cardiovascular instability also, right? So that one we can pay attention on that one too. Because that's her, she has a history of her father already died with a cardiovascular event with a heart attack, right? So we're gonna be following the same path too, right? If you don't pay attention on that too, so.
So this might be a good time potentially for a meeting with her nice community pharmacist to do a medication check review, look at how everything's
correct,
going.
yeah.
Cool. Okay, thanks, that's great. Go for it, Angel.
I wonder, is this an appropriate question? How do patients or clients access the chronic pain program that two people have mentioned here? I'm just wondering, I'm not sure where the access point is that Drake.
Yeah, Drake, feel free to jump in. This is like your dream right
Yeah.
now. We talked about this, man. This is great.
Okay, if I sound like a sales...
planted her for you.
Oh, sweet,
Yeah.
thank you. If I sound like a salesman, just throw a tomato at me or whatever you have.
We'll
at
get
your
the hook. You
table.
got 10 seconds.
Yeah, okay. Myself and then Susan Group, if anyone else I'm missing, let me know. But a couple of us are from the Alberta Healthy Living Program. Couldn't be easier to send a referral. You'd call 403-388-6675. You're pulling out your phones now. Wow, that's great. But you can get patients to self-refer. We don't need a formal diagnosis because we found about 1 in 5 of our patients have no formal diagnosis. And I think we could talk about how long it can take to get a diagnosis. We don't want to delay patients years. So 403-388-6675. And we have a bunch of resources there for information further. Go over things like pain science, we have exercise, nutrition, a bunch of other team members as well. and I'll stop my plug there, but, wait times, if you call in, you'll see me in 2 weeks for a little phone call. We do an 8-week series every month, and if you do not like groups or Zoom, we book 90-minute intakes. We give that time with patients, one-to-one, and we support anyone in South Zone, so Crow's Pass, Medicine Hat, Brooks. We have physical colleagues in Medicine Hat as well, and everything's free. That's the other thing that gets asked all the time, yeah. Yeah, I'll stop there.
Can you see that number slower? The telephone number.
Oh.
What was that? Sorry.
403-388-6675.
Nice. You look at this is great. We're already going to question 4. I love it. Suzanne, may I bug you? I'd like to take a little trick back to the spiritual side. And again, not to pigeonhole the spiritual side, because these things are all fluid. They're all fluid. In your experience, in your day-to-day, if Amy was coming in to visit you in your office, what might be some sort of conversations or queries or fishing lines that you might sort of go around on the spiritual side? If it's okay if I ask you that. Yeah,
Absolutely.
thank you.
So I don't know, as a clinician, having people come into your office, maybe by nod of head, sometimes when you start talking with people and you start talking about spirituality, you feel like you're kind of maybe a fish out of water, because people come from all different walks. Their spiritual practices can be unique to their experiences, to what they've taught based on their values. For myself, I see a lot of Indigenous clients coming through the clinic, and sometimes their spiritual grounding is very strong. They have a connection to the land, they have a connection to their community, they rely on elders, they rely on ceremony to help them with their daily walk through their pain experiences and journeys. They find a lot of strength through that, because sometimes when you're looking at medicine, we don't have the answers. I was sitting here thinking about, I think Penny, you made the comment, you're like, oh, I wonder if there was a way that clinicians could provide more maybe, and I don't want to say stability, but maybe answers when you are going through that chronic pain journey. Sometimes flat out, we don't have that answer. I would love to have that answer for you. I would love to see all the clients be able to go through their journey successfully and have the best quality of life. That's why I went into medicine and enjoy where I practice. However, what do we do when we don't have those answers? So physiologically, maybe we haven't found anything wrong. That's always really frustrating for our clients. Emotionally, maybe we can refer them, we can recommend, but again, that's very individualistic. We can look at best practice, we can look at the latest research, we can trial things with our clients that may or may not work. When we start getting into the mentality, again, the education piece of it, it's very individualistic. Some people will really desire to go and educate themselves if you give them, a little bit to go on in the tools that are there that we know of. There are tools out there that we don't know of from different cultural practices, from different values, from different beliefs. And then we get to spiritual, which is a very personal, individualistic journey for every human being. That also delves in with culture. So having that conversation with the person, really being able to, at this point, if you think about Amy, she's been coming to see us now for 3 to 6 months, so we do have some form of rapport. If things have gone well, then talking about spirituality could be the next step and an easier conversation. If things haven't gone well, so maybe Amy's expectations or her perception of control or lack thereof isn't going well. We've referred her to everybody here, let's say, but she's still not finding those answers. She's still not feeling as good as she thinks she needs to be at, or her expectations of where she needs to be are not there. So really connecting all of those points from physical, mental, emotional, and spiritual, or body, mind, and soul, is how I like to look at it. It is such an individualistic journey for people, but super important for being able to allow them to have control over their situation. Really, I am there almost as another tool to support them on their journey, and give them some help where I can help them in that way. Yeah.
Thanks, that's great. Shanna, go for it. I see the mic moving there. Jump on it.
Yeah. So just kind of piggybacking off what you were saying there, and like the emotional impact, as well as like needing to approach it as an individualistic like situation. And I think the hardest part, and this is from my personal experience, sitting across the table from somebody 3 to 6 months in with their life completely uproared and completely changed, and now opening up to compassion, and I'm sitting across from someone saying like how difficult is that? And one of the questions we often ask in therapeutic recreation is, how are you coping? Some people have answers, some look across and say, I don't know, I'm not. And the hardest part, I think, is that people want those answers right away, and everyone's journey, and you guys are all healthcare professionals, I'm going to assume, in the room, but or know someone living with chronic pain, is that whether it's chronic pain or any other medical situation, is that the answers might not come when we are wanting them and needing them. And if we can support individuals in this 3 to 6 month window with having compassion and empathy and curiosity, I think that allows them to then move into a space where they can begin to think about, how can I advance, versus being stuck in that moment. And the reality is that it might be longer than what they anticipate. And so how can we support them emotionally, spiritually through that journey?
Yeah, thank you. Yeah, just a reality check. Trevor, I saw you twitching. Do you have to jump on in? Yeah.
Sounds good, thank you. You get twitchy, apparently. No. No, I'm just joking. No. You'll have to do, I'm hard to offend. Anyway, looking at the 3 to 6 month period there, really, from all the different clinicians and lived experience with Penny, looking at that personalization for each individual from all these different realms of our overall health. And Drake had mentioned the exercise component within the chronic pain as well, which is what I represent with our supervised exercise program at Alberta Healthy Living, which is really personalizing movement programs and exercise programs to each specific client based off of their goals and health goals. So looking at, if somebody's coming in saying, yeah, I would like to better manage my pain, but pain isn't what encompasses the person. There's so many other things I'd like to work on within my movement. How can we direct our attention towards those things? Within that, and looking at this personalization on top of the peer support, I feel lucky. Our program offers clients programming for up to 12 weeks, again, free of charge, twice a week while we're doing that programming. And both with their personalized exercise prescription, if they are seeing physiotherapy, normally we'll have them bring that in to amalgamate those two worlds as well. But then also to be around others who might be out moving with a variety of different conditions, because it's not strictly people living with chronic pain that we'll see. We might be there for cardiac rehab, pulmonary rehab, a whole variety of different things. So getting that shared experience with others having similar, to have that support and normalizing, maybe even being able to share stories. Yeah, hey, I remember being there 4 weeks ago. This is what I might have developed. So having that personalized approach with the peer support, something that in discussion with clients, and having that personalized movement program to help progress in ways that are meaningful to them, and then assigning value back towards those from the personal perspective to say, why is this movement of value to my life? What am I trying to reinforce by being able to move in this way? So a slight distraction from the pain and more into the overall functioning and the overall health of the person with that personalization and the peer support that comes along with it.
Cool, thanks. And Galal, you have a perspective working in private practice too, and you've treated a lot of chronic pain patients, I would bet the farm on. I'm curious about what you think would be some things that you might bring in to your treatment sessions working with a patient at this stage of the game in your experience.
And I've worked with, many different therapists, and like you mentioned that broad physio term, there's some of us, love manual therapy. Some of us practice acupuncture, the more Western version, dry needling. So it's odd when some people say physio doesn't work for me. Like Drake said, I go, well, what type of physio didn't work for you? because we've all gone to different schools and different courses. So I've had many experiences. One of the ones, and there's people here in the room will remember one of the ones I keep going back to, and I often combine. Was, and I mentioned to Diane, a wonderful physio practitioner, David Giles. David isn't 92 now, but he took his experience and put it together in this 12-step program and gave it to all us physios to look at. And it was hands-on, but it wasn't promoting a dependency where you can't survive without me. I remember David once said to me, if they don't get better in 3 to 4 treatments, I'm not the one for them. Which was very honest of him. And as a clinician, you have to be honest too. Am I the one for you? Is this working for you? Or I know a different clinician who I think would work better. You know, not to be too proud to say, I don't have the skills for this. And I think in Lethbridge, all us therapists know each other enough that we know that person loves treating this. How about you go there? And keeping that communication open. You know, I've worked with great acupuncturists, and in chronic pain, it just can break through that to get people started. You know, there are people who are coming in, I can't move, I can't do anything, and that's a great place to start. You know, as long as they don't mind needles. I was going to say it's non-threatening, but you know, a skinny needle can be, so you have to get past that. But so in the chronic pain thing, the one thing, the team approach, and sometimes I lack that I can't work just by myself, that you know, do you have a counsellor? What's your stress like? And you've all mentioned that, like, where's your stress? Because if their stress is high, I can't move forward. Manual therapy, acupuncture, like, where's your stress? Exercise, and how are you blowing off that stress? Do you need a counsellor? Can you afford a counsellor? That comes up a lot with people I see. They can't afford $175 an hour. So we have to be realistic too. There's a lot of people out there, that's their food for the week. And I'm very conscious of that. They go, I'm just able to afford you. So that's a sad sometimes that we can't get them counselling, or OTs who run pain programs. So it's nice to hear about the pain program, because I do believe in that team approach, you know, and having a kinesio, like, can you take them and work them at their level? So I can't throw them into a gym. Sending people in pain into a gym, they've lost confidence. And so a big supporter of the team approach, and a big supporter of which clinician suits you, which technique. And I mean, ultimately, I want them moving and getting their life back. But how do we support it? So which clinician works for you? Which technique or techniques?
Yeah. Awesome. That's great. And again, the teamwork will come back as we go. I think it's a good time to take a break. I'm fidgety because I'm a physio. I can't sit, and I forced you all lovely humans to sit. So why don't we take about a 20-minute break for all the various things that we need to do. There's some snacks and drinks in the back, and then we'll reconvene at 22.